ازاي الصحة؟ الأمراض المعدية والوبائية هي واحدة من أكثر التحديات اللي بتواجه أي دولة عن تنفيذ خططها للتنمية. فما بالك لو الدولة دي هي دولة نامية بتفتقد للخبرة والبنية التحتية والكوادر المدربة عشان تواجه هذه الأمراض. ضيفتنا هي واحدة من أهم الخبراء الدوليين اللي وضعت القواعد الاسترشادية لمواجهة أمراض زي فيروس سي والإيدز. ضيفتنا هي فيليبه إيستربروك خبيرة منظمة الصحة العالمية والأستاذ بإمبيريال كولدج بالمملكة المتحدة. Professor Filipa, thank you very much for joining us. And it's a pleasure to have you on our podcast. ازاي الصحة?
Welcome.
Thank you. I'll start with my first question. What inspired you to be an expert in infectious diseases?
Well, I think it's always interesting to reflect on the influences in choosing a particular path. And I do think a critical contributor was my early experience of traveling and being adventuresome and going on overland bus trips to India and working in a mission hospital in northern India. And then the following year, actually traveling through Egypt and backpacking down the Nile and going to Sudan, working on the refugee camps in eastern Sudan and southern Sudan and into Uganda, being at the front line, and infectious diseases being a very important and an apparent aspect of those experiences. So really a combination of adventure, feeling a very strong connection with Africa. I think it's interesting how a particular place and an environment can move and influence you. And I think another key factor was that I was never attached to one organ, like a heart or a liver. What is very interesting about infectious diseases is it affects multiple organs. So people can have pneumonias, can have meningitis, and it can involve the heart, it can involve the liver. So it's interesting medicine. It's not just one organ, it's multi-system. And I had an interest in immunology as well in terms of the basic science. So I think it was that unique combination of adventure, travel, connection with parts of the world that are most affected by infectious diseases, combined with wanting to be able to work with multiple infections, multiple diseases that affect multiple organs.
You have mentioned several times low middle income countries, Egypt, India, and Africa. So I assume you have been working and collaborating with several researchers from these countries.
Well, that came later in my career. So that was describing the initial influences in that direction. But collaboration and working in those countries became a defining feature of my career path afterwards. And I chose to particularly focus in a number of infectious disease areas, and HIV being one of the most important in the initial stages of my career, and then moving on to viral hepatitis C and then viral hepatitis B. Mm-hmm. And I think the decision to focus on HIV was very much determined by the most extraordinary, pandemic of the age at that time. And that was when I was in the early stages of as a junior doctor, and starting to see cases, starting to see patients. Nobody was quite sure what it was. And then it became such a huge problem, and there was no treatment, and everybody was dying. And so for anybody who was starting to move down that path of infectious diseases, this had to be the major focus. And of course, the fact that the low and middle income countries, the poorer countries, were so profoundly affected. That was also a key influence, and and I was wholly committed, not just to researching the issue in the context of a high-income country, but the whole issue when the drugs did become available. How do we make those treatments accessible? How do we set up systems so that others in less resource settings can benefit? And then with the viral hepatitis, that came later when I was at WHO. Mm-hmm. And because I was working in HIV when I first arrived at WHO, and then suddenly there was a cure for this infection, this chronic infectious diseases, hepatitis C, in 2014. Incredibly exciting. And it was decided at WHO to move the very, very small hepatitis program into the HIV department, because it was understood that many of the lessons learned from HIV could well apply to hepatitis C in how you make treatments available in other parts of the world.
Perfect. One of the things that is it's quite interesting is that as a scientist yourself, you're mainly focusing on the research, on the patients and the studies, while as an infectious disease expert, you had to deal with other things like the hospital management, policymakers, the gaps between low-middle income countries in health services and in the high-income countries. So these are different experiences that you have been learning, I do assume, over the years. But how were you able to merge between what you're really focusing on, research and academic work, and the different experiences that you need to keep on going and doing your stuff?
Yes, you're right. This has been a journey, a career journey. And so as many who qualify for medical school, you just always assume you will be taking care of patients. That's why you went to medical school. That's your interest and passion. And then as your career evolves, opportunities start to emerge. And I sometimes call them aha moments, where suddenly you see things differently. And so I started out conventionally. I graduated from medical school in Cambridge, and I then went to do my general medical training in an excellent setup in Oxford, got exposed to different specialties. And then HIV came about, and I was advised to go to America. They called it the BTA, Been to America. Okay. And so I got a fellowship to go to the States. And initially, I was always going to work on HIV, but I was going to do basic science, work in a lab. That's what I was advised to do by my mentors. But I had a sudden change of heart in the months before I left, where I fell under the influence of some very world-class epidemiologists and public health leaders in Oxford, who said to me, "Philippa, anyone can be a good doctor." I don't think that was right. Not everyone can be a good doctor. But it's the ability to influence things at a population level. That's the real opportunity to have an influence. And so I was persuaded to change my fellowship from working on the T-cell receptor immunology in a lab to getting training in public health and epidemiology, to really understand the science of data, how you look at evidence, how you generate evidence in a very systematic way. And I went to a superb institution in the States, Johns Hopkins University, which is probably the best or one of the best schools in public health. And I got very excellent training there. And that again started to influence. You started to change your perspective. And I worked clinically in the States as well. It's always good to work in a different place, in a different healthcare system. And that's where I started to do research on HIV. and I worked on something called the Multicenter AIDS Cohort Study, which was a study across multiple cities in the United States, in the US, looking at risk factors for why some people requiring HIV, sexual behaviors, what the progression was, the real basics. And my work was also on racial and ethnic differences. And so for the first time, really showing differences in access, the limited access in the states according to ethnicity. And so I acquired skills analyzing large data sets. I then chose to go back to the United Kingdom. And this was when things had really taken off in terms of HIV. And I worked at what was the largest hospital in Europe in terms of HIV patients. We had 2 wards, 2 24-bed wards, always full, and everybody died. I mean, there was no effective treatment. It was profound, and to be a clinician and be exposed to that. So that's where my research career really sort of took off. And I worked in a number of different areas, and I think my public health training taught me to be adaptable. So to know how to do a good clinical trial, to know how to use patient data from a database, a clinical database, really good analysis that could give you answers. And I also set up some collaborations with excellent basic scientists in Oxford. And I established some very novel cohorts of people who'd been infected with HIV for 10 years and had never progressed. People who'd been multiply exposed to HIV but had never got infected. And setting up some studies to look at what could we learn from these unique patient populations about the genetics, the virology, the type of virus, and the immune response. And I then started to analyze, pool data from a number of hospitals, asking other questions. And so gaining and learning skills in research in a multitude of different areas, collaborating with different scientists. And then 1996, the highly effective HIV drugs became available.
Okay.
And we'd had 1 or 2 drugs before, but this was the turning point. And suddenly we could do something.
During this period, were you working with other low middle income countries?
Well, that was the turning point. I'd had connections with Zimbabwe. I'd spent periods working there. And of course, everybody was dying there. And they still didn't have access to the drugs. But really from 1996 onwards, that's when I really shifted my emphasis. And I was very busy clinically managing HIV patients, working in the hospital, as well as doing my research. But really from then onwards was that shift to saying, what is now important is the most affected regions of the world having access to the treatment. And so that's when I started to work in South Africa. And at first, I was doing a lot of training because the drugs were just starting to become available, but nobody knew how to use them, how you set up services. So I spent a lot of time in South Africa, really training the doctors and nurses, sitting in the clinics in some of the most affected regions, doing basic training side by side. And what had happened, of course, was that the drugs, which were super expensive, already there was an understanding about generic drugs. So instead of it just being the commercial pharmaceutical companies, asking large sums of money in high-income countries for these drugs, was making these drugs available at low cost. And so finally, that was going to be possible. And then I was there to really help make that possible.
There's lots of similarities when you're talking about through the history of the HIV the access to treatment, the availability of drugs and the generic drugs, and the history of the HCV. I assume so, but my question is based on your working experience through at that time. What were the big challenges, if you can order them, working in a low middle income country when the issue of the access to drug is solved? What are the other challenges?
Yes. So I think, and it's always in any response to a pandemic, be it COVID or hepatitis B or hepatitis C or HIV, it's never just one thing. And a lot of people, and particularly, the advocacy groups, focus on the drugs. And the drugs are hugely important, getting the prices down. But there's probably 10 things you need to do to make a response work. And, the drugs, particularly when, for something like HIV, it has such a devastating and rapid impact. And, unlike hepatitis C or hepatitis B, if you don't get access to the drugs, within years, you may die. So the drug access is hugely important. But in addition, you need to have access to the diagnostics. And they need to have a price brought down. And we often find now that even when we've got the drug prices down, the diagnostics are the rate limiting factor. And that also means you've got to have a testing strategy, because it's one thing to have the drugs, but if people aren't getting tested and are not getting diagnosed, so no case finding, as we call it, that's a rate limiting step. And you need to have a strategy. You need to have got some sort of operational strategy in a country, how it's going to work, where the testing is going to be done, which clinic will they go to, how will people know about that. So you need to engage the community. There needs to be community awareness, so that people are aware and want to get tested, and it's made easy and straightforward. And then you need to identify the clinics and train the staff. And you need to have well-trained staff who know how to counsel, and know how to support and know the basics of clinical management. And you need to make it then as simple as possible. And with HIV, it started out as complicated. Everybody had to see a doctor, and they often had to come every week or every month. And it was complicated and it was inconvenient. But you always have to start that way, and then you can start to simplify and simplify. And then you've got to have good systems for monitoring and surveillance so that you have good data. And you need to have a good system for tracking patients so that if they don't come back, you've got a system and a database in place. So these are just some of the elements that you've got to have in place, and it's never just one thing.
How long it takes to have an effective system, and who are the main stakeholders that you think that should be included from the start?
Yes, so I think when you're wanting a national response, you need to engage clearly the Ministry of Health. You need them on board. And in turn, the Ministry of Health needs to have the Ministry of Finance on board. It's not just all in one ministry, because the resources and ensuring that there is that political commitment and that political will so that monies are made available. Because even if, as in the unique situation we had with HIV, where we had these global funders, the Global Fund, the PEPFAR, the President's Emergency Fund for AIDS Relief, these were massive, massive donations and contributions. But you still have got to have the government buy-in and the government commitment. And so I would almost put that above everything else, that political will and the commitment is very important, as of course with the Hep C response with, Al-Sisi's very visible commitment.
President Al-Sisi.
Yes. So I think, and then in addition, you've got to engage at the provincial level or the district level, so it's not just at the national level with the program folk, but you need to have it at the district or facility level and the facilities. So getting clinics established and getting those doctors trained and motivated. And you need to have the community. Community is absolutely essential. And particularly in the HIV response, where you have a lot of your population living in rural areas, in villages, and to have that alliance with the community are key. So everybody needs to be brought together to work in a united way.
Let's focus now to your 14 years experience at the WHO. You have elaborated and explained a bit what should be done on the ground, but following to your working experience, how were you able to turn these ideas into reality, and what were the challenging points or the issues that were difficult to be implemented and the others that were easily implemented?
Well, it's interesting to start out with how I ended up going to WHO, because I was running a department. I was professor of HIV medicine. I was very busy in a hospital. I was in South London then. And actually in South London, it's a very ethnically diverse population. So something like 70% of my patients were from every part of sub-Saharan Africa, some from Asia. Very interesting medicine. And I was still seeing some of the what we call opportunistic infections, the HIV-related infections that other parts of the UK had stopped seeing. But because people were presenting late, being diagnosed late. So that's where I was, and I had a very busy research program working with, again, many other countries already. And then I was given the chance to go and work in Uganda on a sabbatical to become head of research at a superb institution in Kampala, Uganda, a public-private partnership that was established at Makerere University, where I basically was setting up research programs, training, capacity building, mentoring PhD students, setting up a clinical trials unit.
Professor Fيليبه, when have you decided to switch your career from a full professor to a WHO expert?
Well, it wasn't in my life plan at the time to go to WHO, and it wasn't an organization I'd had much engagement with. I was working very busy, running a department, working on the wards, and doing my research in a very interesting institution. And in South London, the patient population was very diverse. About 70-80% of my patients were from all parts of the world, and particularly sub-Saharan Africa. And I'd already started to establish a lot of collaborations internationally across sub-Saharan Africa, Zimbabwe, South Africa, and Uganda. And I was then given the opportunity to go on a sabbatical for 1 year to be head of research of the Infectious Disease Institute in Kampala, a fantastic public-private partnership where I was helping establish clinical trials unit, train the next generation of infectious disease researchers. And it was at that point that I started to become aware of the WHO and their guidelines and policies on HIV. And various people advised me to go and spend some time at WHO to understand more about the research to policy interface. And that interested me. How does one influence policy? How can I use my research expertise and understanding of the evidence base to contribute? And I only ever intended to go for a year. But of course, apparently that applies to a lot of people. They go for a year and then you get sucked into the vortex and get busier and busier. And I ended up staying for 14 years. That's a long time from being 1 year. And my initial focus was on HIV. And I learned the craft of how WHO does its guidelines and its policies. And they're very rigorous, very rigorous, more than any other organization I know. And it's a skill set, and it's a craft, and it's important. And I went there to really also learn what WHO does. And after a year, I still wasn't fully cognizant of all the things. And even after 2 years, it takes a while to understand all the different operations at WHO, not just in the department I was in, but the vaccine group, those working on diagnostics, those working on infection control, those working on maternal and child health. There are many different players. And of course, it's not just headquarters. You've got 6 regional offices, and then you've got country offices. How does this all work between headquarters and regional offices? So I was spending a lot of time really fully understanding. And the main focus of my work, and I guess the main achievements, were around, first of all, the guidelines and the policies. And I really did learn and understand how to do that well.
When you say guidelines, is it per disease or per disease in a country specifically, or region? Per disease.
Per disease. We're writing guidelines, global guidelines, that can be used right across the world.
How would that fit low middle income country to developed ones?
Our focus is on particularly low and middle income countries. So we're not writing guidelines for the United States or, Canada or, Portugal, although there are some general principles that would apply to all countries.
Even with that, there is a broad difference between low income country to a middle income country, and even cross middle income countries. How were you able to have a guideline that would fit all?
Well, you're absolutely right. And, that's part of the, I guess, the mandate and the skill is to have these core recommendations that can be universally applicable, but then the implementation can be adapted to a country context, to the health infrastructure, whether nurses can prescribe, what is the 3-level structure of the specialist district hospitals? Do they have community health workers? Many, many differences across countries. And of course, the epidemic will be different, which populations are affected. So it's having broad principles that can be adapted and applied differently. So the intention is always you write these global guidelines, and many of the principles will apply, universally. There's rarely a situation where you would do something in one setting but never do it in another. It's the way it's implemented, it's the how that differs rather than the what.
Were you revising these guidelines every now and then to see how far it was easily implemented or not?
So you've got to constantly keep your finger on the pulse, see if there's new clinical trials, new drugs, new approaches coming out. And so, particularly in HIV, there were a lot of changes, a lot of innovations, and how things started out at the beginning and the drugs you had changed profoundly. There was so much innovation and evolution in the drugs, new diagnostics, new ways of delivering services. And so it needed changes. And then there were some areas that had been neglected, some of these, infections in those with HIV that caused a lot of deaths, where there weren't good guidelines on how to treat them. So I spent some time on that. Even skin diseases I worked on. And then hepatitis, the cure, became available. And that was when the opportunity, where it was recognized in the HIV department that this is a disease group we should bring in to work with us, because we think we can apply everything we've learned, not entirely everything, but many things that can help accelerate the response to hepatitis C, and particularly how can we have low and middle income countries gaining access. And I was asked to join that group and bring in the skills from HIV to that area. And that was in 2014. And for me, that was very exciting, because being an infectious disease physician, it's never one disease. You're always looking to how you can cross-fertilize from one area to another in management and in the public health response. And by that stage, I had the clinical skills, I had the research skills, and I had the public health skills, and so was ready and eager to apply it to a new area. And of course, it wasn't just hepatitis C, it was hepatitis B. And WHO laid down the gauntlet with these ambitious plans, saying, we're going to write a strategy, not just to manage this, but to eliminate it. And so that was 2016. And the World Health Assembly was when we, in 2016, launched that strategy, where it wasn't just another document saying we're going to work towards this. It was, we think we can eliminate this if we do the following things. And we've modeled this mathematically and shown that if you can reach levels of coverage in testing and treatment and vaccination, it's feasible, it's possible. And I think that was a very important thing, because it gave a clarity and a goal that invigorated the response.
I believe you have been working closely with the Egyptian physicians and the National Committee for Fighting Liver Diseases through the years, and you have been witnessing the screening program, the treatment, and all that. After all these years, how do you appraise the journey and the work on the ground that have been implemented in Egypt?
Well, I think it was very exciting to be part of the Egypt response, really right from the start. I mean, things had started before, drugs like interferon that has a lot of side effects were being used before these new drugs became available. And hepatitis C was such a major problem. Everybody knew somebody who'd had it or a relative who died, so this was very much in the consciousness of everyone in the country that this was a major problem. And so I came very early on when these drugs became available. And actually my first visit was a meeting with Wahidas, who was chair of the committee at the time, where Gilead was just about to make available at a lower cost the drugs. And there was a negotiation. And it was literally in his office that we were discussing what was the right strategy, what was the right approach. And the Egyptians developed the strategy and were really just starting to put all the building blocks in place. But there'd never been anything like it before. And I think what defined the response initially is you had a lot of specialists. Uniquely, there were a lot of hepatologists, liver specialists in Egypt. So it was quite a centralized and specialist-led response, which was good. That absolutely worked in Egypt because you had that capacity and that skill set. And very quickly, these drugs became available and at low cost, and it was the rock bottom price. It started out at $84,000 for a cure for 12 weeks, and quickly it was, a few $100s, and then prices tumbled, and it was setting up the structure. And I think what happened initially, a lot of people got treated. I mean, these were simple drugs, easy to take. And then, a very interesting learning experience was suddenly having launched this register where I think 1 million people in a few weeks had logged on electronically to register that knew they were Hep C positive. And I remember visiting in 2015 and doing a review, and literally you were climbing over people. The clinics were so busy. It was an extraordinary time. And then they started to run out of patients. And the next important step was the case finding that I mentioned earlier. Every response, you've got to be systematic and do case finding. And I think there was the sudden realization, and because specialists were very much leading the response, and normally patients come through the door to you and you treat them, you don't normally as a physician get involved in going out to the community and case finding. So it was a new concept, but that's what needed to happen, to completely change the paradigm and say, we are going out and we're going to case find. And initially it started small and then it grew bigger. And then this vision of we're going to test everybody, or a very high proportion of people. And so that launch of the, Healthy Lives concept was the real shift, and to show that it was possible. And it was a huge mobilization. I mean, a phenomenal operation with teams, health facilities, outreach, and 67 million were tested in a short space of time. So it's the power of the possible, the fact that you can do this, and most would never have thought it was possible. And then linking them, and because you already had these infrastructure and you had these specialists and you had these units, so you didn't have to go out and set up new services. So you got the prices down, you treated the initial one, so there was confidence that the system was working. And then that final step was, let's go out and blitz this and screen,
sure,
and case find.
There had been lots of policy making plans to share the Egyptian model with other neighboring countries, with African countries, Asian countries that still have the issue of hepatitis C burden. My question is how to have a successful sharing of experience or across South countries.
Yes, and I think the whole concept of South-South learning is hugely important. Often people in Rwanda will hear about what's going on in the UK or data and research from the UK and not hear what are some good practices going on in countries nearby. And, Kenya doesn't know what's happening in Tanzania. And there's lots of innovation and good ideas and, energetic people. But that systematic sharing, and it doesn't happen well in the UK. You often don't know what's happening in the hospital down the road that may come up with some good ideas. So this is a good concept. And I think the Egyptian experience really energized people. It inspired people. But sub-Saharan Africa is different. It has a different epidemic. Hepatitis C is not in the general population to the same level at all. It wasn't a general, so it was often high-risk populations that were more likely to have it or in certain areas. So applying the same approach of this mass testing when the overall burden and prevalence is much lower in many African countries, and nor is it as important as hepatitis B. Hepatitis B is a more important problem in sub-Saharan Africa. I think where Egypt was really helpful is in some of the access to the low-cost drugs, and there was a support and offering of access to some of the drugs. But to really make a contribution, it's contributing in a way that's going to create sustainable change. A fly in, fly out is not enough. And so I think it is thinking through very carefully what are the elements of the lessons learned that are applicable to this very different profile and healthcare infrastructure and epidemic profile in sub-Saharan Africa. And I think that just needs a lot of thought and planning, and to do things that are going to create sustainable change. and for those who are visiting those countries to really understand their health infrastructure, because otherwise it's like two ships passing in the night if you don't fully understand the environment that you're supporting. So I think South-South learning, hugely important. And I think Egypt and Pakistan, for example, have very similar Hep C problems. And so I have spent a lot of time in Pakistan, and some of the models I work with on village community test and treat that I work with colleagues from northern Egypt on. I've been, introducing those to Pakistan. So that is where there's a kind of similar challenge and where they do need to do exactly what Egypt did, which is mass testing. And then there are some other settings which have some commonality with Egypt, but it's a bit of a matching game.
You're a member of the COLDA, the Conference of Liver Diseases in Africa, and the SOLDA, the Society of Liver Diseases in Africa. And I have attended the conference, and I've witnessed the vivid discussions across physicians, scientists, bringing new ideas and talking about practical work. To which extent this content of value could be easily transferred to policymakers, so that when they plan for their health policy, they would include the outcomes of these researches in different African countries. How far to bridge this gap?
Well, I think this is a conference where people are exchanging ideas, data, approaches, and I think at this conference I was also talking about the policies we have and the WHO policies. And so a lot of the discussion is, how do we implement? How do we adapt? What are the research gaps? And that's been a lot of the discussion. What are the critical studies to generate further evidence that can then influence the policies and influence countries? But the big gap at the moment is the hepatitis B guidelines, which followed on from the Hep C guidelines, is everybody thinks they've got the right messaging, but it's now how we make it happen at country level, and they need to update their guidelines with the new recommendations and then put the mechanisms in place, train the healthcare workers, get people tested, do the case finding, all the same things all over again that we've talked about, and get those on treatment, and then start to simplify the care pathways. So this conference is really to energize and debate and discuss, and for people to be making sure their ministries of health are updating their guidelines and moving things forward.
Okay. My last question, one of the trending topics these days, whenever the scientists are around, is the digital transformation of the healthcare sector, AI that would revolutionize everything from the basic medical services to the whole ecosystem. How far do you believe that technology would have its impact to push things forward in the healthcare system?
Well, I think it's very exciting. And I suppose I have a view of being intrigued, excited, but circumspect. And I think what a lot of us are doing is learning as much as we can. I think at all the conferences I go to all the AI sessions, and it's usually the presenters are all under the age of 35 and they're all very energetic and dynamic. And I suppose I see my role is also, with AI, it remains a bit of a black box in terms of the interface with the health sector. Coming up with these algorithms, there is a lack of often clarity. It's a bit of a black box. how they got to that algorithm, what was the data that was used to generate that algorithm, what is the data they're now going to use to validate that algorithm and continue to finesse it. And that lack of clarity and transparency. And we do know, for example, some of the kind of cancer predictive models of, individualized care, precision medicine, are based on data from North America, from high income settings. And there's a lack of data, even in the States, it's mainly, for example, white ethnicity, and more men than women. And so it's very important we are questioning and challenging and demanding and requiring transparency, because we can be swept up in the momentum and enthusiasm, this is going to solve all problems. And so that's really, I'm enthusiastic and passionate, but still guarded. And to really be very strategic about what would be the initial phase of contributions. And we need to be wary of replacing overnight doctors and healthcare workers and individualized interactions with anything that could circumvent, the importance of a healthcare worker-patient interaction. So I'm looking for data and evidence that shows me certain things are now well-tested, well-validated, that really will be part of a toolkit, some additional tools in the toolkit.
Professor فيليبه, thank you very much for joining us today.
Thank you so much.
زي ما عرفنا النهاردة، مواجهة الأمراض الوبائية أمر ممكن، خاصة في ظل الدعم اللي بتوفره منظمة الصحة العالمية من خلال القواعد الاسترشادية لتطوير الكوادر الطبية وتطوير البنية التحتية لكل دولة. استنونا الحلقة الجاية، وإزاي الصحة.